Did it work? Awesome. All right, so now we should be at our SAEM main homepage. At the top right in the center there, you should see meetings and events. So once you click meetings and events, scroll down a bit, and there should be a panel that says log on to SAEM. All right, and if you are there, at the top it should say SAEM 21.
Good morning.
Good morning. How are you?
I'm doing well. How are you?
I'm good. I'm just going to rename myself here.
Okay.
How's the conference been going for you so far?
It's going good. It's going good. One more day left. 1.5
Yeah.
days. Yeah. Countdown. So you are the MSA, right?
Correct.
Okay. When the speakers come on, if you could just introduce yourself and let them know what your role is today, that would be very helpful. Thank you.
Awesome.
How many sessions have you been on?
Working. I've been on a few yesterday. And then luckily I've been able to sit in on quite a few that have been really interesting for me. So yeah, quite a few now. I've really enjoyed this. This is my first year helping out as an MSA.
Okay.
So yeah, it's been
Very
awesome.
good. Good. I am just going to be doing some work in the background. So I am going to turn off my video camera and mute myself.
Okay. I'll do the same. When I see people come on, I'll turn on everything and say hi.
Yeah. So let's see. We have 1, 2, 3, 4 speakers we're waiting for.
Awesome.
Okay. Thanks.
Thanks.
You're on mute.
Hey, Margaret, if you don't mind if I ask a question real quick.
Yeah, go ahead.
So I wasn't a co-host before. Are the presenters also going to be co-hosts?
Yes, so the presenters will also be co-hosts. I made you
Okay.
co-host just in case I missed to admit someone into the room.
Yeah,
or if-
that's perfect. I'll admit Eric right now then, because he's coming on in.
yeah, and Eric is a presenter, so if you can give him co-host as well.
Perfect. Thanks.
You're welcome.
Hi there, Dr. Legum.
All right. Good afternoon.
Good afternoon. How are
Good
you?
afternoon.
I am well. Let's see if I can get on.
There you are.
All right, look. How's that? Okay.
Perfect.
Can you make me look a little thinner?
Oh, can you
No.
make me look thinner, please?
My collaborators should be on relatively soon.
Okay,
We have one. I'm going to control the slides. We have a few. We don't have that many, but I can do that. And then there's everyone else will just talk. I have all of them with me. And it's controlled just, I was at the Juno thing, but it seems like you've moved to a Zoom platform.
so yes, so all of the presentations are in the Zoom.
Thank God. That was a rough introduction.
Okay,
So let me just make sure I'm going to pull up the slides real quick just so make sure it looks okay.
sure.
And Margaret, I don't know if I'm allowed to make people co-host as a co-host. I don't have
Okay.
the option here under more.
Sure. I got
But
it.
I could, okay, I can admit people though and help out with that.
Sure. Brendan, well, I'll admit the speaker so I can also make them
Okay.
co-hosts as well while I'm doing that.
Cool.
All right. Brendan. So I'm going to just do a share screen just to make sure it works okay.
Hold on.
All right. Are you able to see that okay?
Yes.
Okay. I could just leave that up, right? That's fine.
Yes, that's totally fine. Will you have any breakouts today?
No.
No?
No, I think we
Okay.
just have, I think it's a 50-minute session. Is that right?
Yes.
Yeah, so shut everything else down on my computer just so I don't pull it by accident.
And then I'll introduce myself again when the other two presenters show up. But I'm Nate. I'm your guys' MSA. So if you guys need help with anything, happy to help however. So
Great. Thank you very much.
of course.
I'll stop. I guess I just leave the share on, actually. How's the meeting going so far?
It's been going well. It's
Good.
been going really well. Yeah. Especially everyone's adapting to this virtual meeting, which, it's a lot different than in person, that's for sure.
Right. No, I think we're used to it.
Yeah, I mean, it's different, but it also gives the participants the freedom to log in from anywhere they're at and pop in and out and, take other calls if they need to.
Yeah, that's sometimes good and bad. There is some benefit of just you're there, so you can really focus. Sometimes it gets hard but it obviously is. We're kind of used to this by now. So I watched a few of the sessions and they seem great. So is the attendance, is it up or down? I wonder, just because it seems like there's just so many opportunities to do. Seems like there's more opportunities this year to go to things, but also people are doing it from home maybe.
So this is this is my 9th day here at the association. So I was not involved last year. The most participants I've had in a session were, I believe, 77.
Oh, okay. Well, that's not bad.
And I just finished my first year of medical school, so this is my first year in the conference. So I as well can't give you any indication of how it is compared to last year.
Fair enough. Last year we canceled it, right? It was supposed to be in Atlanta, and it was canceled altogether, wasn't it?
It was, yes.
Mm-hmm. Great. Okay, hey Randy. So, Randy, can you see the slides on one of these?
I think he stepped away.
Yes.
Okay, good. So I'll control them. Nathan, are we able to chat with each other privately? How does that work? Just briefly.
You should be able to hit participants and not hit chat, and then if you go to the everyone and click that caret next to it, you can individually like private message each person. But I don't think there's a group messaging, like a small mini group messaging option.
All right, so I can just like individually send something to someone. Can you see it if I have this up in front of the slides? Can you see it on your screen?
No.
Oh, okay, good. Okay. So So you guys, if you want to, if I'm not moving fast enough with the slides or there's something I'm missing or you want me to move something, just let me know.
Okay.
And if people post questions in the chat during, would you like me to interrupt you at a good time for the questions, or would you like me to just tell people to wait for questions until after the presentation?
You know, after I do the introduction, I'm going to be moving people through a little bit. I'm probably going to keep my mouth shut most of the time, so I'll try to monitor them. But if you see something I'm missing, if you want to just either text or chat me or just say, hey, those questions, something like that. I think it's fine.
Awesome. Awesome. Yeah, I can individually message you for that. It shows up as red, so it's easier to see with that as well on the individual.
Okay. What's this thing on the chat? It says go slower, go faster. Do I need to do anything with that, or? Oh, that is.
Where do you see that?
In the little chat box, there's a thing on the bottom that says yes, no, go slower, go faster, more.
I don't see that personally. It might be a presenter thing, like since you're sharing.
Got it.
But
I'll just ignore it. It's fine.
Eric, are you introducing us, or wait, is this
Yeah.
your only slide, or are you
So
gonna,
no, I got a quick one, and I have a little bit around about all of you.
okay.
I reached out to your first grade teacher and got pictures from.
I hope not. And then, so wait, show me the next slide. So then Hina goes
And
first.
so that's that side. Then it goes into Hina's
Okay.
slide, your slide,
Okay.
Brendan's slides, and then I have some at the end for Hina if we end up getting to them.
Okay.
And somehow I just closed this. Let me reopen it. Where Hina is, because I thought she was getting on early. I'll just text her real quick.
Hey, Eric, I'm off the phone. Sorry, I wasn't paying any attention. My volume was turned off, so anything that was directed at me, I didn't hear it.
No, just a quick kind of overview. So as long as everybody can see the slides, I'm going to run. I will give a quick
Right,
back.
I'm sorry, wait, are you wearing a sport coat? Holy mother of.
Somehow I knew you were going to say something.
I love it. I love it. I love it.
Yeah.
I was getting texted all day through SAEM saying, wait, who else is on this thing? This is just, it's just us kids, right? Yeah, all day I was getting texted saying, man, it feels really different that we're not staying up till 3 o'clock in the morning and then trying to show up for the 7 a.m. lectures. Yes, it does. Much better for my life.
Yeah, not as much fun always, but you know.
That's fair, but those nights are hurting more and more as we continue to gray.
Yeah, I couldn't quite make it to putting a tie on, but I did figure the jacket was probably
I
appropriate.
still haven't ever seen that.
I have about 7 of them in my closet right there.
I thought it was pandemic casual for the first year, but now I'm realizing it might just be you.
I think when I made the switch,
I received an itinerary for a work trip one time, and it had like, casual, business attire, and the next one said disaster casual for when we sort of showed up after the earthquake in Haiti. Disaster casual, I did not know was a type of dress.
Brendan, just to let you know, this is how I have the slides. So I'm going to do a quick introduction, briefly introduce the presenters. Hina's, Rondi's, yours.
Yeah, mine are like if we want to tell stories. So I'll just say, hey, can we tell the story of example 1?
Okay. Hina's.
Rondi, did you make one that you feel proud of?
A slide?
Yeah, it looks very pretty. Is this the one that you made? When you were shamed? I love it.
No, I redid the whole thing last night. Or whenever I sent it to Eric.
Wonderful.
It's like Hina's having a little bit of trouble, so I'm going to try to walk her through it real quick.
It was like it was actually very, very easy for me. It just jumped right to a Zoom.
Yeah, I hit attending and then clicked on the link and put the code in.
Okay, put on the link. So So just turn.
Is everybody else, did it somehow know that I was me, so it gave me this access, like magic?
I let you in, I think.
And other people, do other people get view only or something?
So I've given.
Oh, you know what? If I click on the link now, it takes me into that other room.
Oh,
Ruh-roh.
How do we get her into this?
Yeah. Margaret, are you in charge?
I'm sorry. So
Where is
yes,
she?
all the presenters I've given co-host rights to, so our view will be different from the attendees.
Can
But
you
Dina
see all the
can't-
attendees and convert an attendee to a presenter? Is she in the wrong room, Eric?
I don't know. So I can see it though. I looked again. I see her. Oh, hey, Hina. Is she in our Zoom room?
I can go over and bring her over.
Yeah.
I see what's going on now. Yeah, I'll be right back.
It's like he actually went somewhere. I'm gonna go over and bring her over. Like, I'm gonna get her.
Hey,
She's in the wrong conference room. I'll walk across the hall.
Hey there.
I'm not sure where he went.
Let's see. Oh, I'm hearing myself in the echo. But if you go to the link down here, the maximizing databases.
Nathan, I can still hear you.
Let's see. Brendan, we need to catch up today again. Never ends, huh?
It never ends.
And she's on. Hina, I think I can see you.
Yeah, I just brought her over. I realized you guys could hear me the whole time. I
Yeah.
think it's because this a lot of us have this SAEM screen up as well, so I was just dual mic'd there. I couldn't hear myself talk as the
I
echo.
can't see the other people.
Is your I just see a blank you. I don't see your video either.
Okay.
There you go. Hello.
Hi.
So
Is she also a
just-
presenter?
yes, she's the presenter. So Hina, just can you see the slides? Okay.
I can see the slides and I can see you, but I can't see the other speakers.
You gotta change it in the top right, probably from single view to a little.
Yeah.
block.
So go to the top of your screen. It says view, and you'll just go to gallery view. You see it? Top right-hand corner of your screen. Is there something that says view?
Oh yeah, look at that.
There we are. You can also grab that little box and pull it to the side so you see more people. And you can just like split screen it with.
Right. Okay. No, I don't. I mean, I've only been using Zoom since March of.
You should also change your name.
but
so they don't have to call you.
I did the. How do I change my name?
The three dots under your little box. Right next to it.
Rename. Look at that.
If
Oh,
you-
see that I didn't know.
Just a fair warning, unless you change it through like the actual like Zoom profile outside of chat, you'll have to change that every time. Just so
That's
like
fine. I just need to get it
that's-
done for now.
That's
all.
perfect.
We can work on the future in the future. I did the training and I had no idea that it was going to be through Zoom, because even at the training, someone specifically asked, can we change backgrounds and things like that? And I have to say, I spent an inordinate time to make sure that the background in my office would be okay.
Did you hang all that this
Um,
morning?
No, but I just took all the garbage away from behind me.
People are showing up as entering the waiting room. I don't need to do anything with that, right, Nathan?
No, Margaret, is it time for us to start admitting people? I can't tell if that's
no,
nice.
not yet. Joshua is the moderator.
awesome.
So I let him in and
Oh
I
yeah, I
I
see
thought you
that.
snuck in.
Are people watching on Juno or are they watching on Zoom?
They'll be watching on Zoom.
Hi, Joshua. Would you mind introducing yourself and letting them know why you're in the room?
Yeah, so I'm Josh Gutman. I'll be moderating this section. That's why I'm here a little bit early.
And for those that weren't here earlier, I'm Nate. I'm the MSA. So any help you guys need, just let me know. I'm not Zoom proficient, but I can find my way around. So
What's an MSA?
That's what I was going to ask.
Med student
Metropolitan
ambassador.
Statistical Area.
So something similar to that, yeah. Med student ambassador. So I'm a medical student that's usually in-person conferences. I was told we do a lot more, but with this, it's more just helping things flow smoothly.
And I'm Margaret, and I work for the association, and I will be here for any help you need, technical or otherwise. Once the meeting gets started, I will go ahead and mute myself and turn off my camera, but I will be actively listening in the background. So if you need anything, just say my name or say help, or you can chat me directly in the chat box. Everyone will be in the waiting room until it's time to start. And if you can please let me know when you would like to start, and I'll admit everyone.
And I'm fine as soon as we hit, I guess,
11
now or two
Okay.
now.
Sure.
Any last thoughts?
Gonna be great.
Dr. Gelbard, we missed you down at Emory. Where are you now?
I'm at UAB.
Oh, awesome.
Yeah.
Not too far away.
How are things over there?
Busy. A lot of good new hires though. So there's a really good group of trauma
Yeah.
surgeons.
Okay,
Yeah.
we have 3 people waiting. I'm going to admit them. Please feel free to start when you're ready.
I'll wait another
A
minute.
few minutes or so, maybe or two. Yeah, hopefully we'll have more. So there's about 40 or so signed up.
We'll wait another minute or so. Sometimes people sign up to a bunch of them and then decide later because it puts it on your schedule. Okay, in order to allow the speakers to have the most time, so let's get started. So this is a didactic on maximizing databases, opportunities, options, and future directions for cross-specialty collaboration, which is an AGEM and trauma interest group sponsored, co-sponsored didactic talk. We representatives from emergency medicine and trauma surgery, so it's really wonderful to hear from all of you, and I look forward to hearing this talk.
Can you get started?
Yeah.
Great. So hello, everyone. My name is Eric Begome. I'm from Mount Sinai, Morningside and West Mount Sinai Emergency System in New York City. I just want to give you a little bit of background as we start out. So first, this talk was sponsored through the SAEM Trauma Interest Group in a collaboration with EAST, the Eastern Association for the Surgery of Trauma, which was initiated through their Emergency General Surgery Group. For those of you who are familiar with EAST or not familiar with EAST, it's a moderate-sized surgical-based organization with about 2,800 members, but also has members from multiple specialties. Although it's moderate-sized, it actually has had an outside influence on much of the work we perform in emergency department as it relates to surgery. Many of us are familiar with their work on clinical guidelines, and many of us, including myself, have participated in writing some of them in the past. We may not be as familiar with some of their multi-center trials, but we do hope to change that today. So East has worked with emergency medicine to develop collaborative relationships, and today's forum, which discusses the use of databases and research and helps further the idea of the benefit of collaborative cross-discipline work to find better care and patient outcomes. So with that, let me introduce our panelists. So first we have Dr. Hina Santry. Dr. Santry is an associate professor of surgery at The Ohio State University. She is an acute care surgeon. She is director of the Center for Surgical Health Assessment, Research and Policy at The Ohio State's Western Medical Center. Her research interests include the psychosocial and structural factors that impact outcomes for injured patients and emergency general surgery patients through epidemiology, biostatistics, survey research, qualitative research, and geographical mapping. Rhonda Gelbard is an associate professor at the University of Alabama, Birmingham. She is director of the Trauma and Burn ICU and the chief of critical care services. Her ongoing research projects include single center studies focused on outcomes of traumatic brain injury to large multi-center trials in the management of complex trauma patients. Dr. Brendan Carr is a professor of emergency medicine and assistant chair at the Mount Sinai Health System in New York City with an appointment in the Department of Population Health and Science and Policy. He is focused on building regional systems of care for emergency care, developing innovative delivery solutions to create a more distributed and accessible acute care delivery service. He previously served as director of the Emergency Care Coordination Center and a senior advisor within the United States Department of Health and Human Services between 2012 and 2020. He was also recently elected to the National Academy of Medicine just last year. Myself, I am, as noted, I'm the professor and chair of emergency medicine at Mount Sinai Morningside and West, which previously known as St. Luke's and Roosevelt in New York City. My research actually has not been database focused, but it has been related to a significant amount of interdisciplinary research and collaboration, and I am very pleased to present our work today. So I am going to start out with Dr. Santry, who's going to talk a little bit about database research in general and get us started. Dr. Santry.
Thanks, Dr. Lagone, for such a kind introduction. It's very exciting to be here today on behalf of the Eastern Association for the Surgery of Trauma, and it's been wonderful to have worked with you on the Emergency General Surgery Committee under the leadership of Dr. Gelbard over this past year and a half. And today, I hope to have this be a little bit of a discussion with my colleagues here on the virtual stage, so to speak. But a lot of my research has focused on administrative data or other sort of existing data sources as at least a route of starting clinical inquiry. And I wanted to spend a little time talking about that. For people who are interested in research focusing on population health, epidemiology is a method that can be done, though it requires robust hypothesis-driven statistical methods. There are lots of existing data sources that can help us ask the kinds of clinical questions that come up in our routine practice. And so I want to start talking a little bit about the different kinds of data that are accessible. And now this is just a brief slide, just as a placeholder during the conversation that I hope we're going to have. It is not meant to be, exhaustive in any way. But when we talk about existing databases, there are generally, historically, three kinds of categories. Administrative data is typically derived from the UB40 billing sheets that are generated after any inpatient or outpatient encounter. And then they go off to various sources and are cleaned and put together typically in de-identified form in different resources. And so billing data that goes out is submitted to the Agency for Healthcare Research and Quality's Healthcare Utilization Project and collated into a number of data sources. So HCUP provides the national inpatient sample, where they provide a statistical sample representative of all admissions in the nation annually. Within HCUP, they also have NEDS, which is the National Emergency Department sample, which, as the name describes, focuses on emergency room presentation admissions, whether or not they resulted in an inpatient admission, and also the state inpatient databases where the national inpatient sample is derived from state data to create a single uniform data source. The state inpatient databases sometimes vary in the content that they have, but are designed and released through each individual state via HCUP so that you can do uniform comparisons across states. There are a number of other resources that are available through that website. ResDAC, on the other hand, is actually a product of the Center for Medicare and Medicaid Services. It's their research arm. And so any billing data that goes through them in a very similar fashion gets culled, put together, and available as data sources. And Medicare data is available in various different formats. So you can, get just the Part D claim data, or Part A claim data, or Part B. You can get combinations therein. You can request data for specific disease entities that you're interested in, or you can request 5, 10, 15% random samples. There are some institutions, including Ohio State, where I work, where there are agreements in place to have access to all of the Medicare claims data. And so there's, again, various resources involved. And a lot of these clearinghouses, which I'll get to in a couple of minutes, are not just about providing the data, but making sure that research best practices are used in, conducting research using these data. And then the all-payer claims database console that I show here, each state that has an all-payer claims database, where Florida and California are sort of the most well-known, they have available data sets. So I could be living and working here in Ohio and can acquire the Florida all-payer claims database in order to conduct research. Again, these are all based on billing sheets that leave the hospital and have various different data available based on what the purveyor of the data has set standards. On the other hand, there are registry databases that are available as well. These registries are formed sometimes by professional organizations, sometimes at a regional level, sometimes from a research perspective. So the National Trauma Data Bank, which would be relevant to a lot of people attending this workshop, is a voluntary registry across trauma centers nationally. The American Joint Replacement Registry is a product of an association, the American Association of Orthopedic Surgery, but was done as part of a prospective study measuring quality of life outcomes among patients that are getting joint replacement. And then the SEER Medicare project, which is a huge resource for cancer research, is cancer registry data that is submitted from various sites across the country that then gets linked to billing data from Medicare. And so again, these are just some examples of registry data, but most hospitals will have, say, a trauma registry or a cancer registry, and then those can then get brought to higher levels in order to facilitate research. There are a number of quality programs.
Before do you want to break and see if we want to talk a little bit about that distinction? That distinction for me, when I was coming up in this, was super blurry. I didn't really understand the difference between administrative and registry and when you would use one versus another.
Sure.
Could you just riff a little bit on sort of, the pros and the cons before we sort of jump into quality programs?
Sure. The registry data is, generally speaking, at least some component of it, chart abstraction. And so in general, that is considered higher quality data because a human being has gone into the chart and extracted some data. That process, of course, is only as good as the training and the people, but most registries to participate will have a process for judging inter-rater reliability. And if they have any sort of mandate, like trauma programs mandate registry participation, and they actually give hospitals guidelines for if you have, for each 500 activations you have per year, you need to have one registrar, so people can, keep up with that. Administrative data, on the other hand, is purely billing data, which has a lot of limitations, right? So there's no clinical granularity. There are, systems that third-party vendors have created to give measures of severity of illness based on billing data. 3M has a tool that HCUP offers, but in general, you're not going to know if the patient truly was in florid sepsis at the time that they presented, even if they have a diagnosis code of sepsis in their, anywhere from, to 25 diagnoses that are available in the data set, because both the timestamps and the sort of association between the actual clinical findings and what was billed is not necessarily clear. And then the other thing that is important to understand is when you're using billing data, especially as a surgeon, this is very important to me, a lot of times what bubbles up to the top in terms of a primary diagnosis or a primary procedure is the one that generated the highest level of reimbursement, which may or may not have anything to do with their primary reason for a presentation.
If I could jump in, I think it was a good comparison of the two. But I would say, using these the registry databases, should be done with some caution too, just because of the inherent bias associated with a convenient sample. So, if you have a trauma center that includes isolated hip fractures, for instance, in its registry, and another doesn't, and the mortality associated with that injury is lower than other injury patterns for patients with the same injury severity score, then that's going to skew the risk-adjusted mortality for that center, and so can produce a selection bias. So that's just one of the biases for these database studies, and like Dr. Santry mentioned, this data is abstracted by registrars, but that they abstract this data from progress notes and other things that are captured. So if the data is not captured, it's not going to be in the database. And so some things may be underreported for some centers and are reported well for others. And these are still being benchmarked against one another, even though the data may be incomplete for some places. So I think you have to keep all of that in mind if you decide to use NTDB or a similar registry database for these studies.
Yeah, that's great, Ronnie. The one thing I would add on the end of that is that these two, well, it's the HCUP data, the NTDB, your state trauma registry data. These are really friendly data sets to cut your teeth on. They're really, the fields are discrete, they're well organized, they're clean, and you can really start to write code and learn how to sort of do this kind of work. We up in the administrative piece, you lumped in ResDac. It's like a whole nother level to start playing around with Medicare data. It is just administrative data, it's claims data, it's all billing data, but it is cumbersome and it takes a lot.
Yeah, no, and absolutely statistically, and that's why it is critically important to have a biostatistician on your team as these things get, more complicated. The Medicare data is very complicated to use. The SEER Medicaid data is that much more complicated because they've linked two data sets together. And, I think oftentimes though people do think, well, this is low hanging fruit. The data already exists. I've got a med student who took a stats course as an undergrad. And oftentimes you actually need a little bit more expertise than that. But some of these data sets do lend themselves to, doing smaller projects to learn statistics and whatnot. And what Dr. Gelbard said leans into the quality programs, which are actually very similar to registries, but they are sort of prospective active programs where the participants get, routine feedback, whether it's quarterly or, once a year or twice a year, on how they are performing relative to others. And then that data is continually used to actually robustly risk adjust, or at least people will say that. And so most university hospitals participate in Vizient, that used to be the University Health Systems Consortium, and they have a database that is available to participants. The National Surgical Quality Improvement Program is another database. TQIP is the trauma version of that. And then a variety of our surgical societies, the STS, Society of Thoracic Surgeons being one of them, have these sort of prospective quality improvement databases, which is part of a sort of an ongoing performance improvement plan. So it's a little different than registries, but still typically based on chart abstraction, often will have longer term data up to at least 30 days. Some programs will even go as far as a year out, like transplant databases, because that's what's required. And then, you know, there's ever evolving new resources that are coming through from various sources. So this is not by any means an exhaustive review of things. And so if you are a junior faculty member or a novice researcher who's interested in getting started, there are a number of resources, and I'd be curious to see what my colleagues here have used. But in 2018, JAMA Surgery came out with this really great issue where, like, there was a detailed article on using, you know, the HCUP databases, on using the quality databases, on using Medicare data, which is a very, very useful sort of like starting point for understanding what the potential might be of these databases. The Society of General Internal Medicine has something very similar on their website that's freely available. You don't need to be a member. Again, it goes through a lot of these various databases, including how to acquire them. Some of these, if you're a participating institution, they're available. The participant use file is available for free. Others, there's a fee attached, et cetera. And then there are various workshops that are available now, mostly online due to pandemic. However, you know, they've always been both online and in person. To be able to go to a meeting or to take a 2-day workshop through various organizations, to get familiar with the databases, to get familiar with some of the common codes, to get familiar with some of the processes. Are there any programs that, Rondi, that you found that are particularly helpful?
You know, they have ones for most of them, I think, initiated by the state. So I know in Georgia, my prior position at Emory and Grady, they would do TQIP workshops to learn how to interpret the data and to be able to use that for qualitative studies and for quality improvement, and performance improvement. So there are state initiated ones as well.
And, you know, the American College of Surgeons has like a research course that I'm not sure when they're going to offer it again, but there's no reason why, you know, anyone from any other specialty could register for it. And I have sent 4 research fellows in a row there when it was offered. And it was just really like a 3-day intensive, but you get like a really good exposure to the data sources and how to use them, you know, effectively. And, you know, all of these databases are very useful for just the classic, you know, I'm interested in, you know, representation. Like you can look at the database to figure out how many times someone might have, like, you know, emergency department recidivism after being, you know, admitted with, say, UTI or something like that. Or, you know, they present to the ER, how often do they come back with something like that? So sort of classic epidemiology, whether you're looking at mortality, recidivism, other complications. There are ways to use these data for process assessment as well, in particular the quality improvement programs, which will have data on, you know, number of minutes spent in the emergency department, or time to OR, time to consultation, the number of the sort of people that were scrubbed in the OR when an operation was done. Health geography is something that, you know, I've done, whether this is looking at how people are connected within the healthcare system, or how they're either the facility zip code of residence or the person's zip code of residence plays a role in their illness or injury presentation, distance from site of injury to the trauma center, which is data that can come out of the trauma registry. So there are various different health geography questions that can be answered from these databases. And then some of these databases will include costs and charges. And it does take a fairly astute person to sort of figure out the differences and to add this sort of geographic cofactor that is needed to determine what the actual cost is versus charges. But you can do cost effectiveness research using these databases. And the sort of how-to of this is, you know, outside the scope of this talk, but, you know, the process is, we are all clinicians. I feel like this work is based on ideas that come to us while we are taking care of patients. So if an idea comes to you, brainstorming with colleagues and maybe even presenting your work in front of a group of peers, every institution that I know of at this point, whether it's based in a department of surgery, whether it's university-wide, there are health outcomes research centers, health services research centers, et cetera. In particular, if you're at a place that has a surgical health outcomes research center, trauma divisions are very big divisions, acute care surgery divisions are very big divisions. It's a great way to find a partner and to be able to ask some of these, questions that overlap with the work that's done in the emergency department, and then the patients that we might admit to an acute care or a trauma service. When you want to acquire the data, all of the data sources have the tools and what you need, but it's very important to follow all of the steps. So there is a process to get vetted to see if you are able to use the data. There's a process to get it. There is a commitment to making sure that data is stored appropriately. Even if a data source says that it is de-identified, you should always at least have your IRB vet a data set before you use it for research, even to be told it's exempt. Don't make that assumption. So you can get a Medicare de-identified data set, but like our IRB here still considers it, identifiable research, and it needs an expedited IRB approval. So it's very important to be able to stay in terms of the research ethics part of it, to make sure that you abide by all of the parts of the processes. And then I'm a big fan of taking your question, templating what you would want to know before you move on to the analyses. So you already have what your paper might look like templated before you move on. And then of course, hopefully you can sit back and disseminate.
Thank you. I'm going to move on to Rondi. One quick question. For most of these data sets, are these freely available, or do they charge to use them? Do you require to have some funding prior to getting a hold of them, or do you have a sense of the differences?
Sure. I mean, I have personally purchased a Medicare data set that came with Part D claims, which are quite expensive, for $40,000 or $50,000 to be able to ask questions on people who were on anticoagulants when they presented to the trauma center with head injury, those kinds of things. It all depends. So if in general, if your institution is participating in a quality program, the participant use file will in general be free to you. Okay. And all of the others will probably have some kind of a cost attached to them, but depending on your institution, there may already be a process to actually make it available to the individual researcher cost-free. So those institutions that already have 100% Medicare data availability, you can't just go use it. You have to go through the various steps to get permission to use it, but it ends up being a lot cheaper than paying the sort of larger bill. So the honest answer is some are freely available, but others, they may or may not cost money. So it's important to look into it, and don't just always buy a data set, always check at your institution to see if they have it available.
Yeah, can I just add to that? I mean, so the ARC data is actually, especially for trainees, is unbelievably inexpensive. I haven't looked in years, but it's literally like $100 or a couple $100. Whereas you're right, we sit on hundreds of thousands of dollars of Medicare data, and it's painful to think that you're going to answer one question with it. Which brings me to the bigger point, which is you probably shouldn't be doing this alone. Hina's already made a reference to the fact that you want to partner up with people that are, sort of experts in the analytic approach to this. But there's someone on, and I imagine we're talking in general to people that are sort of relatively junior, early in their career. There's someone on campus who has depth of knowledge about how the machinery works at your institution. Or there is someone who is doing the kind of work that you're interested in at a different institution, who's sitting on data and also has partnerships with people that can help you to kick tires on ideas and think about analytic approaches. It's okay to grab data and sort of play with it on your own and learn how it works. But it's really important to acknowledge that most science in this space is team-based science. The ideas that you have as a clinician versus the sort of analytic skill set that your friend who's an economist may have are different, and they're much better when they're complementary.
That's a great lead into our next speaker, Dr. Gelbard. Why don't you tell us a little bit about EAST and some of the trials there and some data sets.
Absolutely. So we're going to shift gears a little bit. So we kind of talked about databases that are already there at your disposal. sometimes for a fee, but the data exists already. So what do you do if you want to build your own database, if there's nothing out there that really captures what you want to look at? So there are options for building your own database. So and the best way to do this is really through a multi-institutional or multi-center trial, especially those that are endorsed by trauma societies or other organizations. So several trauma societies, like obviously East, Western Trauma is another one, the AAST, they really do a good job of supporting high quality multi-center trials on trauma, emergency general surgery, critical care. And these are generally investigator-led studies, and they really provide a really good forum for collaboration among different investigators and institutions. And I've been involved in this for years. I think I've been a member of EAST for 7 years, and I now chair the Emergency General Surgery Committee. So really work closely with the multi-center trials group and sort of a collaborative effort. So say you have a clinical question you want to ask, and no existing database is out there address this question. So how do you go about starting a multi-center trial to potentially generate the data to answer this question? So it's pretty straightforward. I mean, I won't say it does take some legwork, and hopefully you have help. I have done them independently, and it is a lot of work. But the best way is, even if you want to initiate this on your own, it can be more efficient if you seek support from one of these organizations that I mentioned. So first thing is you go through their approval process, and most of them have a call for proposals that's either annual or biannual. I think East has now moved towards twice a year that they actually elicit proposals. And so it's all web-based, online. You come up with your proposal, you submit your proposal, which will include things like background information, your specific aims, hypothesis, outcomes you want to look at, any variables that are to be collected, and generally a data dictionary so that different sites can follow and know how to interpret the questions and the fields that you're asking for. So you submit these, they're reviewed by the Multi-Center Trials Committee through these various organizations. And just something to keep in mind is that a lot of the ones that are typically approved for sponsorship are more prospective, even maybe randomized controlled study design, although those tend to take a little bit longer to recruit enough patients. But prospective observational typically get supported. It has to be feasible. It has to have a clear, concise study design, and really something that can be completed in a short time frame, 1 to 2 years. They don't want these studies dragging on for 4, 5, 6 years and not generating anything tangible. So if your project is selected, the respective society will help you recruit sites. They'll do advertising, often on social media. They'll send mass emails to the membership, and then you have the opportunity to present your study idea at plenary sessions at their annual meetings. And so this generates a lot of interest, and you'll get emails back from different sites. Oh, I want to sign up, and a lot of the sign up can be done online through the respective society's website, and then each individual site will start their IRB process, their local IRB, or if you decide to go with a more centralized IRB, that's fine too. And then once the sites get IRB approval, it's moving on to getting data use or data transfer agreements so that the lead site can get all of the data, so that they can share basically the de-identified data with the lead center who's coordinating this project. And then while this is going on, the lead center, if you're the one organizing the study and you're the lead PI, you're thinking about, well, how am I going to collect this data and store it? And so I particularly like REDCap. And for those of you not familiar with REDCap, it's the nice thing about REDCap, it's secure, it's web-based application for really building and managing online surveys and databases. It's completely customizable. It has the ability to use a data dictionary template in Microsoft Excel that you can then upload to REDCap. And then once data is collected, it can be downloaded into or exported into Excel, a PDF, or any statistical package for analysis. I think it's very user-friendly. Your institution may have, it's not free, but my hospital, for instance, I think pays like an annual subscription, and if you have a new protocol, it's like a nominal fee, and then an additional fee if you want IT to actually build your database. So as long as you know what you want to put into it, they will create the whole thing, and then you sort of pilot it, and then it will go live for data entry. And so, I think that's a very user-friendly, but you don't have to use REDCap. Some societies will have a centralized database that you could use that most of them aren't free. So you need a little bit of help funding or help from your institution. Or you can just use Excel, which is also an option. But REDCap is nice because it's secure. So there's really, with questions of HIPAA and all of that, and protected health information, you have to kind of be careful with that. So REDCap is nice for that reason. So once you've got that done, then you're ready for data collection and analysis. Usually all the sites will put their own individual institutional data into REDCap. And then as a lead site, you'll have access to all that data to do data cleaning and validation, send queries back to the individual sites so you really get a nice clean database to use at the end. So what about funding? There are funding opportunities.
Andy, can I?
Yep.
Before you move on to funding sources, I just want to point out that, depending on where you are, there may be some motivation, especially to get the junior faculty, fellows, and trainees engaged in research to get involved in these studies, maybe not as the lead center, but as a participating center, because all the participating centers will have at least, one, if not more than one contact who can participate in the publication process as well, the analysis and the, refining the study questions. And then afterwards, oftentimes, once the data is collected, you're not just answering the one main question, but there's multiple other questions that can be answered, with opportunities for many of the participating sites to get first author publications that are related to this. And so I think that even if you, don't have the wherewithal or the internal funding / manpower to be the lead and set it all up, it is a great opportunity to be involved in various different kinds of research studies to be a participating site.
Yeah, that's a really good point. I mean, I think once you have that database collected, then there are countless secondary analyses or post hoc analyses you can do. And so for one of the studies I'm about to show you some examples on the next slide is, we had one looking at the management of appendicitis, and I think that ended up with over 3,000 patients. We can go back, Eric, real quick I still talk about funding sources, but I think we're on our 13th manuscript just from post hoc analyses from that one database. So many clinical questions that could be answered just from this data set that doesn't otherwise exist. So just real quick about funding, so if your institution is not going to support you, that there are other options. So, I would first start with your own institution, though. There's often intramural funding or internal funding opportunities within your own hospital. A lot of places will have seed grants for junior faculty just starting out. If they don't, then federal agencies are another option. NIH, Department of Defense, many others support faculty's early career development. So there's plenty of opportunities. And then the trauma societies that we already talked about support junior multi-center trial investigators with mentorship and scholarship. East in particular, they have an annual trauma research scholarship and a multi-center trial junior investigator award that they award annually to assist junior investigators in conducting and publishing their multi-center trials. So a lot of these societies, and East is not the only one, so those are options as well. And then if you're new to this whole process and you really need some guidance, East is great about constant follow-up, mentorship throughout the process, but other places as well. There's a coalition for national trauma research, or the CNTR, and that's a nonprofit organization that supports high-impact multidisciplinary clinical trials. AAST, East, Western Trauma, they're all there's an affiliate members as well. They comprise the core members of this group, and they don't provide direct funding, but they partner with investigators to provide additional research infrastructure if you want to perform a multi-center trial, and they help you, they support applications to funding agencies. So it's a really good way to get some mentorship, some guidance, some infrastructure if you're new to this whole process.
I'll throw in, if you don't mind me interrupting, I'll sort of say that the Emergency Medicine Foundation and the SAEM Foundation also sponsor on the emergency medicine side of research training fellowship grants that are competitive and awarded annually.
Yeah, great. Thank you for that. And just really quick, benefits to multi-center trials, yes, they can be a lot of work, but I think the return on investment is good. It gives you a larger number of participants and that can generally be enrolled in a shorter period of time. You have the benefit of getting different geographic locations, including a wider range of population groups, and really compare results among centers. And all of that really improves the generalizability of your results and your study. There are some pitfalls. Obviously, a lot of these are prospective, observational, not necessarily randomized controlled studies. There is heterogeneity, practice and clinical practice among different centers. So those can be confounders and something to just keep in mind when you're analyzing your data and interpreting your results. So those should be included as potential limitations when you're writing up your studies. We can move ahead to the next slide. And just
I
to
think
show
they're
you-
particularly, I'm sorry, I think they're particularly useful though for things that are sort of relatively rare at each center. Like, so for example, if you're really interested in electrical injury, that's probably something that you don't see very often, but across, a bunch of participating centers, you could get enough data. And so the burden of each participating group isn't very high, but then you can answer an important clinical question.
Yeah, thank you. Yeah.
Rodney, is there a would you think do you think it's a lot easier in some ways because once one person has really done the protocols and written them, it's very transferable, and a lot of the work they're essentially taking off your plate. You're still doing the data collection, getting the patients, but you don't have to write all of the IRB, et cetera, from scratch. Do you agree?
So if you're a participating center in one of these?
Yeah. So it actually, in some ways, it's relatively easy to join in because a lot of the work is done for you.
Exactly. So generally there'll already be a protocol. You may have to adapt it somewhat to your institution because every IRB is going to have slightly different requirements.
Sure.
Some are a little bit more rigorous process for IRB approval than others. But in general, the majority of the work is done. They will ask to see the lead center's IRB approval letter. But generally you're going to submit the data dictionary has already been created. The data collection forms have already been created. So most of the work, if you're just a participating site, has already been done for you. I have found the rate limiting step for a lot of this is actually the data transfer agreements, because often things get held up in the Office of Sponsored Projects, and it can sometimes take a couple months to get these DUAs because there's a lot of legal issues that can surround it. So that's often the rate limiting step and the part that takes the longest. But in the meantime, once local sites have their IRBs, you can actually start your data collection. You just can't share it on REDCap or whatever data collection your source resource you're using. So just to show you some examples, and I kind of tried to pick ones that were relevant to emergency medicine, and emergency general surgery. These are ones that are bebeing endorsed by the AAST, some current studies looking at timing of cholecystectomy after percutaneous drainage for cholecystitis. There's one for necrotizing fasciitis and soft tissue infection, validating a uniform system for measuring severity of disease. Assessment of EGS care based on quality indicators, and then hospital course and outcomes of EGS patients that are admitted during the COVID era. We're seeing actually a lot of, and I have on the next slide, you can move ahead, as one of my current studies is actually looking at the management of appendicitis and cholecystitis during the COVID pandemic. On the left here is a study that we did looking at, and this started back in 2017, looking at the management of retained common bile duct stones in choledocholithiasis and gallstone pancreatitis. We had about 12 participating sites. This is my first MCT as a PI, as a lead for this study. And so 12 participating sites. I think we enrolled about 1,000 patients. We got multiple podium presentations out of this at various meetings, and manuscripts continue to be generated. The middle one is the one I mentioned before. I was not the PI on this, although I was the site PI at the time. I was at Grady, and this was led by a colleague of mine in Miami, a trauma surgeon. This has already generated over 12 manuscripts. This one study that was also initiated in 2017. And then the one on the right is my current study that we're also the lead site here at UAB. And that's, as I mentioned, looking at appendicitis and cholecystitis and how the management may have changed during the COVID pandemic. We have about 20 actively enrolling sites, about 1,600 patients so far. And enrollment's only been open for a couple months, and we hope to get some abstracts out of this to be submitted for the next East meeting. So, and then below that, we're not the only multi-center study looking at COVID, EGS management during the COVID era, but there's some international multi-center studies going on as well. I just included the titles below. So that pretty much sums up. I know this is like a lot of information crammed into a short period of time, but you can always reach out to me, email me with any other questions if you're interested in leading an MCT, and I'm happy to provide some guidance.
You know, Rondi, it seems like just looking at these, you know, there's some that clearly are very limited to not to the emergency department, but there's some, especially the appendicitis, that clearly impacts what we do and how we practice. Do you see some of this? How many of the studies do you see, I guess, have emergency medicine collaborators as part of them?
Yeah. I mean, I think a lot, because even the COVID one, you know, I think especially, you know, patients presenting to the emergency department, I think our management of some of these conditions has changed, especially at the height of COVID, when we were at our peaks, and either we didn't have OR time or hospitals were full. And if patients didn't have an absolute indication for surgical intervention, we were managing a lot more of this non-operatively. And I think we also moved away from laparoscopic intervention to more open surgeries. But even identifying these patients, I mean, there's a role for emergency medicine and even identifying these patients. And, you know, the examples I put up here, you know, there are some that that may be more relevant. I mean, looking at imaging. So do we give oral contrast for small bowel obstructions in the emergency department? And there's been studies looking at that as well. So, you know, this is just a little snapshot of some of the studies going on, but honestly, there is a role for emergency medicine in a lot of them. And the nice thing about some of these is that this could lead to guideline development. So, you know, if we can answer clinical questions about the role for, you know, radiographic workup for some of these conditions in the ER, you know, non-operative management, you know, can patients go home with a course of antibiotics for uncomplicated acute appendicitis, things like that. So there's definitely a role for emergency medicine in a lot of this.
Thank you.
Can I just say in parentheses here for people that don't know EAST, I know EAST, you know, reasonably well, but in the language, the name is surgery of trauma. For most trauma surgeons consider themselves to be much broader, and you're hearing it from our two collaborators here, that they are acute care surgeons, and, you know, the importance of, you know, everything from a non-operative management of an abdominal process to the imaging and workup of an abdominal process. To consider that that is all in scope really changes the way that we think about partnering across societies. And I would, correct me if I'm wrong, but I believe that that is very, very much in scope at EAST these days. It is not just the trauma side of things.
Correct.
Correct. Yeah. I mean, they haven't rebranded. And the you know, comment that I was going to make was that the opportunities are endless, right? So, you know, Dr. Gelbard and I really only ever meet our patients in the emergency department. And so just because the question hasn't been asked, even if it is a question that is initiated by one of our colleagues in the, you know, in emergency medicine, it doesn't mean that it is not relevant to an organization like the Eastern Association for the Surgery of Trauma and worthy of a, you know, multi-institutional study.
Yeah, so Eric, you don't need to jump forward with this. Sorry, I was going to say, I have put some examples in here so we can contextualize this and talk about what I think is the special sauce of the next step. You've heard some pieces of this. Dr. Santry said, you know, talked about the SEER data, where you take clinical data, mix it in with claims data. Clearly, Dr. Gelbard's talking about the idea that you're going to collect data, you're going to have a rich data set. Dr. Santry also talked about geographic data. When you start to let your brain stretch out a little bit and you think about all the different data sources that you could bring to bear to answer your question, is when it gets really super fun. And I think my inclination would be to sort of pause and see if people have questions they want to talk about. Otherwise, we can talk about examples of contextualizing this and the richness that can be created by thinking outside of the box a little bit. But in Zoom world, sometimes it's hard to read faces about questions. Okay, well, so throw them in the chat, and with your permission, Eric, can I just talk about one thing that we're doing? So one of I asked Dr. Santry about the tension between registry data and administrative data or claims data or you know, insurance data, whatever it might be, Medicare data. You know, the summary version in my mind of that is, and actually you heard Dr. Gelbard bring out individually or specifically selection bias. So I spent a lot of time studying trauma care in the early days of my research career. And, you know, most clinical questions are answered inside of trauma registry data, but half of severely injured patients are not treated within the trauma system. So unless you're from a state that has a reporting mechanism for all of the patients that are missed by those registry data, you're only seeing half of the outcomes. You don't have visibility on the rest of the system. And so, we spend a lot of time thinking, how can we use claims data to answer a question about how people are doing outside of the trauma system? And the challenge there, of course, is that the richness of the data that you need is in the registry, right? So I challenge you to convince either of our two trauma surgical colleagues here that you can say anything intelligent ever about risk adjustment without knowing like their arrival blood pressure, right? Or pick another 20 variables. It is a really hard thing, but worth playing around with. So if you sort of jump forward, I just wanted to put, shout out to collaborators and colleagues. That blue line there is the American College of Surgeons has an established mechanism by which you risk adjust. This is using that model, but it was work that we were commissioned to do for the state of Pennsylvania. So PTOS is the Pennsylvania Trauma Outcomes Study. And we use the sort of agreed upon risk adjustment tool that is used to benchmark survival by site for trauma centers. And we gave it back to our state. They gave us the registry, we did the math, we sent it back to them. And then we got permission to sort of also tether that data to their Medicare claims, which we held. And we started training our models using machine learning to identify what kind of variables should go into the regression. And then the orange line and the gray lines that you see are two separate regression tools that we are using to see how well we could train our data. So this allows us to see, if we think like this, right, it allows us to say the gold standard is the registry. We have that for half of the hospitals. It's actually a little bit more than half in Pennsylvania, but we have that for the half of the hospitals. And we want to sort of understand what similar apples to apples comparisons would look like outside of those hospitals. And so we went and met with a bunch of machine learning folks, a bunch of biostatistical folks, and you can jump forward to the next one. And, we sort of end up with risk adjustment, and actually go back, because it says O to E. For those who don't know what that is, that's observed to expected mortality. And so go back to the other one. And so, this is comparing the area under the curve for the two different models, one using the traditional model, 0.84 area under the curve, and one using the claims-based model, 0.75. It's not perfect and it's not the same. And we need to decide, right? If it's going to drive policy, if it's going to drive payment, maybe it's not good enough. If it's going to help us to figure out the relationships that trauma centers should have with non-trauma centers around helping to sort of make sure that they share clinical practice guidelines or implement best practices or create educational portfolios, maybe it is good enough. And if you jump forward, the box and whiskers is a means by which trauma centers demonstrate observed to expected mortality. When you participate in many states in the statewide trauma registry, you get your own performance brought back to you, and you're allowed to then compare. You can identify yourself, but nobody else, and you can know where you stand relative to your peers in this agreed upon risk adjusted model. So here, the hollowed out ones are the trauma centers, but all the other ones are the ones that were invisible to us until we started to use this other risk adjustment technique, and allows you to start to think about what outcomes look like amongst the population that you're missing or would have missed had you just stuck with the totally, admittedly, richer data, but data that we heard from Dr. Gelbard, really introduces a selection bias.
Thank you so much. We're unfortunately out of time because we have another session.
I thought this was all afternoon, Eric. You said all afternoon, no?
You can keep going all afternoon. No. But Joshua, this is recorded, right? So if people want to see this later, because I got some text actually during this, someone asked if we could see it later. So
yeah, so they're going to be available on the SAEM platform at the end of the conference for anyone to be able to see. But I wanted to thank you all for coming and sharing your expertise. I definitely got some ideas while looking at this and how to start and where to go. So truly appreciate it. Again, this session will be recorded, so it'll be available at another point at the end of the conference.
Thank you very much. And I put my my email in there. If someone has a question for anyone on here, if they send it to me, I'll make sure everyone can get it to everyone.
Thanks, Eric, for organizing, and thanks to our colleagues from.
Thanks for the invitation. Appreciate it.